Welcome to this issue of Journal Club for February 2023. My name is Dr. Danny Marhaba. I am joined, as usual, by Professor Peter Cameron, and today we are joined by Dr. David McCreary. The studies we're going to talk about today will be threefold. The first manuscript we'll discuss will be the introduction of an emergency medicine pharmacist-led sepsis alert response system in the emergency department. This one's a cohort study from 2023. The second study we will discuss is a prospective, open-blinded, randomized controlled trial on the restriction of IV fluids in ICU patients with septic shock and whether or not it contributes a mortality benefit. And the third manuscript we'll discuss is also a 2022 study titled Peripheral Vasoactive Administration in Critically Ill Children with Shock, a single-center retrospective cohort study. We'll start with the first manuscript.
Paper 1.
This is the introduction of an emergency medicine pharmacist-led sepsis alert response system in the emergency department, a cohort study. The population here was roughly 180 patients presenting to a tertiary emergency department with a sepsis alert during an emergency medicine pharmacist working hours who were admitted to ICU. The intervention here was the sepsis alert response system in the emergency department, which includes early intervention by emergency medicine trained pharmacist. The comparator was the roughly 100 patients who presented to Alfred ED before the trial began, before the implementation occurred, which was the 7th of February 2016. And the outcome was a bundle of parameters, the primary of which was time to administration of antibiotics. Some mortality data was collected, but that wasn't the primary focus of the study. This is an interesting trial, or an interesting study, I should say, not a trial. It comes at a time when we've transitioned from the initial Sepsis 1 in 1991 with the initial SIRS call-out criteria, and it was followed by Sepsis 2, which sort of solidified these SIRS criteria. Sepsis 3 then changed it a little bit to the QSOFA, and now we have the Surviving Sepsis 2021 guidelines. My first question goes to Professor Cameron. Prof, I see here that our call-out criteria for these sepsis alerts is effectively the SIRS criteria with slight modification. They've taken the respiratory rate of 22, the respiratory rate of 20, and we've increased it to 22, I suppose, to increase our specificity. And the heart rate of 95 comes from the SIRS criteria of 90. Once again, we've raised it a little bit to increase our specificity. Do you support, or do you think using these sepsis alert criteria to alert junior medical staff is sort of, I guess, evidence-based or a good idea to implement?
Well, there's no doubt those physiological criteria are associated with poor outcomes. Like there's, I don't know whether there's thousands, but there's many trials that demonstrate that if the physiology is off, you will do worse. The question, I guess, then is, are these sensitive and specific enough to make them the guideline for intervention, and what level of intervention you require at each level of derangement. I think if the blood pressure is 50, then most people would sort of stop drinking their cup of tea and go over and give the patient a hand. And then there's sort of a blood pressure of 80, a blood pressure of 90, a blood pressure of 100, a pulse rate of 120. You get all these sort of, and then there's young women who normally have a blood pressure of 90 and these sorts of things. So when it's extreme, I think everyone would agree, this is a call to action. Once you get to the sort of thresholds, then you're sort of playing off with, sensitivity, specificity, with regard to how much intervention and so forth. And as you know, in an ED, there's always another priority. There's the patient down there whose arm is broken and needs analgesia. There's the patient over there who's got a STEMI, and so you've got to prioritize your patients and your shift. But I think there is no harm in alerting people to the fact that physiology is abnormal. It's really what you do next that the discussion is where you have the discussion.
Thus, my next question, Dr. McCreary. Prof. Cameron's always probably the most critical person in the room of his own studies. So let's start with
critical of everybody's studies, but he doesn't discriminate. He includes himself too. Yeah.
So let's ask: do you think this provides some evidence to show us that if our goal was to reduce time to antibiotics, that the introduction of an EM pharmacist seems to do that?
See, there's what the paper says and what I believe from our own practice. I think there was a lot of caveats in the room on the Journal Club Day as well. But look, because from our own practice, I do feel like it does. And I certainly see it happening when I'm in the room with a septic patient and they are at the door advising me on what I should be giving, sorting it, prescribing it, getting it ready. I have felt the benefit anecdotally. I don't think, and on the day I tried to look at this, if I was the director of an emergency department that didn't have the funding for ED pharmacists and I was trying to convince us that we needed them and using this as a basis, I don't think this study does that, because it shows that there's a benefit in the antibiotics being given, or it could just be the documentation of the antibiotics being given. And it shows that benefit might come from a sepsis call out. I don't think it necessarily shows us that it comes from a pharmacist call out. And I know, and Prof can probably chime in on this, but I know there's probably reasons why they didn't compare overnight when there was no pharmacist available to during the day. But in my mind, that seems to be the main way that you could pick apart the presence of a pharmacist against no pharmacist when everything else, I know that nighttime's different, but I mean, in terms of sepsis call-outs and all the new processes that the hospital went under at the same time, it just helps to pick that apart a little bit better. Because while I know the benefit of pharmacists, I don't know if this paper truly shows it. What do you think, Prof?
Well, it's, forget about where it was done and that they're our dearest friends and all that sort of gear. This paper, it has issues which you can drive a truck through in terms of methodology. And it was an unfunded study, and it was what it was. But, it's a single center study. It's before and after. As Dave's already mentioned, it's talking about a package of care as opposed to just pharmacist or just call out or some other intervention. So all of those things are bundled in together. The time of day, as Dave's mentioned, patients do better during the day when everyone's around and there's no big deal. Overnight, there's less staff, everything's harder, and but they weren't comparing, so they didn't actually compare like with like from that point of view. And then I guess I guess the reality is it hasn't answered any question. What it has done is highlighted that there may be a signal that maybe doing a package to maybe alert people might make a difference. So it's worth doing a proper study to demonstrate that, which would probably take the form of a stepped wedge design, which is because it would be difficult to randomise, day 1 to day 2 or, patient 1 to patient 2, because there'd be too much contamination within an individual site. So you would do it, you would sort of introduce the package at, say, the Alfred, and then at another hospital, and then at another hospital in a random way, and then do before and afters at each site. That's probably the best way of determining whether this sort of intervention works. And you might do it in a staged way. So you might do the alert, and then you might do the pharmacist, and then you might do the, I don't know, packages of whatever it is that's involved in this whole package.
So convert it from a combination of a retrospective and prospective cohort study to a study of therapy, a prospective study of therapy.
Yes. Yeah, I mean, at the end of the day, it's sort of interesting. It highlights one hospital's experience. It doesn't prove much.
Yeah, I think that's the best takeaway is that it may ask further questions. It may suggest or signal towards the benefit of a bundle, which may include an EM pharmacist.
So, and one other thing, just in terms of the outcome measure, time to antibiotic in itself is a process measure. It's not that clinically meaningful, and there is some controversy about how much difference it makes. I mean, if I had septic shock, I'd probably want to get my antibiotics earlier, but for many of these patients, it probably makes no difference. But if it made a difference to mortality or to time in ICU, I might be more.
I think that's a really good point, actually, because the limited evidence that there is for it, it's time from identification of severe sepsis rather than just all sepsis that is where the benefit is. And obviously that some of that cohort's going to be caught in this group, but yeah, it's not measured and it's not picked apart, and you would need much bigger numbers to be able to measure a mortality benefit or a ICU.
There is some evidence that the authors cite that draws an association between time to antibiotics and sepsis and outcomes, but I feel like that's there's a lot of confounders with those studies. And to delay to antibiotics is the same thing as delay to care or delay to EM treatment or overcrowding, and all of these are confounders to it. I like that the 2021 guidelines came out and said possible sepsis up to 3 hours. How do you feel about sepsis 3's definition, though, which I think life-threatening end organ dysfunction that results from a dysregulated response to infection?
I think it's a better definition. I think highlighting that it's the dysregulation as opposed to, and this is my problem with SIRS criteria in general, is that it's the normal response. You're supposed to get a fever, and the fever is going to make you a bit tachycardic and things like that. So I think that those SIRS criteria aren't specific enough in that they take an awful lot of normal response, and it has blurred those lines, and we really need to identify the patients who are having a dysregulation. But in saying that, emergency medicine is a sensitivity specialty, not a specificity specialty. Like we need to identify them all, and there's going to be an element of overtreat in order to guarantee us not missing the ones that really need it. When yes, there's the bigger public health concerns of antibiotic resistance and blah blah blah, but really on a departmental level or a patient level, that's not a concern on the day, and it's about identifying those patients that are potentially sicker. So that's why we want.
Because worst case, you give them some antibiotics and send them home.
Pretty much, yeah. But that's where we have to have the sensitivity dialed up. But I think, like, I do prefer the definition of a dysregulation. But if you wait until you're sure that it is a dysregulation, it's probably too late. So that's where it's really complicated.
Any last thoughts, Prof?
No, I mean, I think it was a nice little study, but it's really more a pilot to work out how you might prove that pharmacists make a difference.
Paper 2.
Restriction of IV fluids in ICU patients with septic shock. This was a multi-center open-label prospective RCT of around 1,500 patients over 18 years of age admitted to ICU who had suspected septic shock. And they defined suspected septic shock by suspected or confirmed infection, a lactate greater than 2, ongoing vasopressors, and having received at least a liter of fluid in the past 24 hours. Their intervention was restrictive intravenous fluids given under four conditions. One was severe hypoperfusion or shock, with the plasma lactate more than 4, MAP less than 50, oliguria, and increased cap refill time. If that was present, they were allowed to receive between 250 to 500 mils. The second condition was the replacement of documented IV fluids, urine output or GI, or any drains that were inserted. The third condition of fluid administration was to correct electrolyte derangement. And the fourth one was IV fluids to ensure a daily fluid intake of 1 liter. The comparator was standard intravenous fluid therapy, which was effectively unlimited IV fluids, depending on the preferences of the treating clinician. The actual intervention, so the actual volumes that were administered, were day 1, the restricted fluid group received a median of 1 liter, whereas the unrestricted received around 1.7. And on day 5, the restricted IV fluid group received 2.3 liters, but the unrestricted group received around 3.8. The cumulative fluid balance was the restricted fluid group were positive 0.7 liters on day 1, compared to 1.3. And the restricted fluid group were positive 1.6 liters on day 5 compared to 2.4. So some differences in fluid, in cumulative fluid load there. The outcome was death within 90 days. They had a cohort of secondary outcomes, which were number of patients who had more than one serious adverse event, defined as cerebral, cardiac, or limb ischemia, or a new AKI, as well as a few other secondary outcomes. The conclusions of the study were that there were no significant differences in 90-day mortality or in serious adverse events among patients who received restricted fluid therapy and those who received standard IV therapy. Moving on to seeing what we can take from this, we'll start with you, Dr. McCreary. What do you reckon? How do you feel about, what do you think about what this evidence guides us?
In the emergency department? Not at all. It's really in the title. And I think when I was reading it the first time, I just highlighted that in the title, ICU patients with septic shock. So even if it did show a big difference, I don't think it's necessarily going to affect us in our management. But yeah, I think even if you are in the ICU, I don't think there's a big enough difference in the fluid given, like the cumulative amount. It's, 1.5 liters difference at one point. It's not massive differences in the fluid volume being given for it to really have mattered, even if it showed a bit of a benefit. I don't know. It just doesn't seem particularly helpful to me. But the things from my side that I was wanting to see that I didn't was, how much fluid did they get beforehand? Where were they at in their resuscitation status from the ED? And and on the topic of that, only about 40% of these patients came from the ED. So that even, a group that's probably not relevant to us, and it's only 40% of them are even vaguely relevant to us. So I'm probably not taking much home from this. I think, from an ICU perspective, they may be looking at it as it doesn't really matter too much what they do, but there's been a general trend over the last load of years anyway that they are going drier anyway. So you're comparing restrictive fluid to standard, but standard in the ICU is to be pretty restrictive. They get the patient flooded before they come to ICU, then dry them out when they get there. So I think I don't really understand where the question came from for them. We had Prof. Andy Udi as well come down from ICU for Journal Club on the day, and he said something similar. Prof. Cameron, how should we structure? Let's say we have somebody who's boarded downstairs. They're downstairs for 12 to 24 hours because there's no beds upstairs. How should we gauge how much fluid we should give them? Well, I think, it gets down to clinical acumen. That's cool. If they're, we just had someone the other night that was about 5 liters down because they've been lying on their floor for 3 days. They needed 5 liters of fluid, and you could tell that, looking at their IVC and so forth was
quite obvious that they were down on fluid. There's the clinical part, and then let's say they appear to be more or less fluid balanced when they come in, as far as you can tell. Then I think most practical, pragmatic clinicians would give a litre or so of fluid. And then if that didn't work, they would use an inotrope, or a vasoconstrictor. So I don't think anyone's going to give, just if they think they're euvolemic, they're not going to give them more than a couple of litres of fluid these days. As Dave said, the fashion has changed. And I think it would be hard to get a trial up that said we'll give one guy 3 litres and the other guy less than 1 litre. I don't think that would get up.
I think the really important thing that you mentioned there is the clinical assessment. You just shouldn't be, and I don't think anybody really is anymore, given these things blind. I actually think capillary refill is probably underrated, but if you look at the Andromeda Shock trial where they used it as the main guide versus lactate, it's such an easy thing to do by the bedside, and I think that's really underappreciated. But I really think it doesn't matter what measure you're using, as long as it's one you're comfortable with and you can convince yourself, this patient probably needs a bit of fluid. That's the big stopping point. It's thinking before you act or before you prescribe. Or
ideally, if you use multiple measures simultaneously.
Yeah.
Like echo, cap refill, biomarkers for AKI or whatever, vitals for hemodynamic compromise,
passive leg raise,
lactate, and I don't know about urine output because they never have a catheter, but
it's just giving it due consideration and making, you're not going to be right 100% of the time, but we have to make the best clinical educated guess that we can. But I definitely agree with Peter that there's definitely a trend these days, and I know there's studies ongoing at the minute for just earlier use of vasopressors like noradrenaline. And you can do that while you're also fluid resuscitating, and you can, fiddle with it that way. But I think that's the direction that we seem to be heading at the minute.
I think the ARISE fluid trial will help us a little bit, but again, it's a little bit restricted by, if you'll pardon the pun, by the amount to which the fluid is restricted.
It's restrictive in how restrictive it is.
Peter wants to restrict it further.
Paper 3.
Peripheral vasoactive administration in critically ill children with shock. A single-center retrospective cohort study. The population was a pediatric or children in a single quaternary pediatric ICU aged 31 days to 18 years who received adrenaline, noradrenaline, or dopamine via peripheral or central venous catheters. The intervention was the administration of peripheral venous access, and the comparator was the administration of vasopressors through central venous access. The outcome was the likelihood of vasoactive medicines leaking from the cannula site. This was a retrospective cohort study. The sample size was 231 approximately patients in the peripheral arm and 525 patients in the central venous cannulation arm. The outcomes were measured by number of extravasation events, the dose of vasopressor during the event, and the number of abrupt hypotensive events, as well as the number of CVA placements in the peripheral vasoactive medicines arm. I thought that these measures were appropriate. They were reasonable ways to assess these two cohorts. And the results were that the initial peripheral vasoactive medication administration group received them in approximately 30%, whereas the central arm received them in approximately 70% of patients. And the conclusion was that short-term peripheral administration of vasopressors was safe while evaluating the need for central access. Dr. McCreary, do you begin administration of peripheral vasopressors in patients, or do you usually wait for a central access in adults?
In patients in general, absolutely use it so often, advocate for it all the time. It is, I think, a game changer, and we know that it's safe as long as it's a good cannula that you're sure is well sited, preferably in a large vessel, preferably proximal, et cetera, et cetera. But the main reason I love it is it just gets rid of a cognitive barrier, because before we started using it, you would often see people going, they might need a bit of NORAD, but then I have to put a central line in. I don't really want to put central line. Then they would leave the central line for as long as possible. And then you were really putting the central line in anger, and you couldn't get it in fast enough. And that's when mistakes happen. Whereas the way we practice today is you use a good peripheral cannula. You start the NORAD, you see that it's worked, you make the decision that they need ongoing definitive access, you put in a CVC while the patient's got a lovely map, and you can do it clean, tidy, calm. Makes so much sense to me. It just, anything that gets rid of this cognitive barrier that stops us using a drug that we're pretty sure helps. I have to say, I don't look after very many critically ill kids. We do see some kids in some of our sites and in other hospitals I work in. And I've worked previously in retrieval services where we would look after sick kids. So I would, have used it, would use it, but it's not certainly my area of expertise at the minute. The use of it in kids, it seems to be, we don't have a lot of literature for it in the adults either, but there's no like trials that have shown benefit, and kids are slightly different to adults. So that was my only question in the journal club on the day. Obviously you would need a different sort of prospective trial to be able to show that there's actually a benefit in using them peripherally in kids, but I don't see physiologically why there would be any difference. And this is just another paper that shows that it's probably a safe thing to do if you're sensible about it.
Next question goes to Prof. Cameron. I finally found my numbers from the 4 screens that were open in front of me. Well, they had 4 extravasation events in the 231 patients, among whom peripheral vasoactive medicines were administered. Are you comfortable with 4 out of 230? Do you reckon that's...
Well, there were 4 out of 230, but none of them required any plastic surgery or any other... dastardly thing. So they were basically 4 harmless, in inverted commas, extravasations. And, you can do 230 without any significant complications, then that would be reassuring to me. My only concern methodologically is that they didn't include those patients who didn't go to ICU. So if they died or went to the ward, got better and went to the ward or something, they obviously weren't included. I don't know, and we don't know what numbers they were or whether there are any problems with those. And as you've mentioned, so in terms of safety, on the face of it, it looks pretty good, because the only thing I'd be worried about is extravasation. In terms of effectiveness, as Dave alluded to, we don't know whether putting it in peripherally works as well as putting it in centrally, but from other studies and limited data, it appears that it probably does. This study doesn't answer that question and wasn't designed to answer that question.
Of the 230 patients who received peripheral vasoactive medicines, half of them did not require a central line in the end.
Yes.
And so potentially that may be the difference that you're alluding to, in the sense that if we have 4 out of 230 that have suffered an adverse event, but it's a minor adverse event, half of them would have been saved a fairly invasive intervention, which is probably associated with more than a 4%.
Yeah. But it's important to recognize that just because they didn't go on to get a central line doesn't mean that the peripheral access noradrenaline or adrenaline was the reason that they didn't get a central line, because it's a retrospective study. You've no idea where an association or causation is. So just bear that in mind when you're looking at it.
That's a good point. Is the reason why the administration of peripheral pressors or inotropes may or may not be effective, is the thought that even if it is in the vein, that its delivery to the central circulation is probably slower, if happening at all?
Yeah, I mean, it may get metabolized, it may distribute, I mean, anecdotally, it appears to work quite well, but
I think at lower doses, I think once you get to the higher doses, I do start to wonder, because it may be peripherally vasoconstricting itself out of the central circulation, and and that's where it's one of those reasons you get a central line in once your doses are getting really high and you're not winning.
And I think this is, with this particular study, it should be realized what it is. I mean, it was a short period that they were using it for. Probably low doses, and as we said, there may be some cases that were missed. So I think it's reassuring for us that if we want to start peripherally while we're getting into ICU or something, that's probably going to be fine. But it shouldn't be to replace central venous administration of vasoconstrictors,
or ultra long peripheral cannulation.
Yeah, I have to say I do like this. I do think it adds to the body of evidence. I would really have liked them to have included all those patients, like all patients in the ED that had noradrenaline or adrenaline or dopamine given to them. Like that's my biggest bugbear with this, is that they just lost such a big batch of patients that would have been really interesting. And aside from that, it really has, it's added a bit to the evidence, which is, admirable.
If I was in a regional hospital or a rural hospital and we're about to transport a patient to a tertiary PICU, and we had a 22 gauge, a yellow, a 24 gauge, a yellow cannula, I guess the question is really a moot question, because if the patient needs vasopressors, give them vasopressors. If they don't need vasopressors, don't give them vasopressors. And if they need vasopressors and you have a 24 gauge in, get a better site, and you can start it in the 24 until you get a better site. Is that?
Yeah, if you can. I mean, I think some of these kids had it in their hand, and they didn't necessarily have any ill effects from that. I think there was one comment in the room on the day of Journal Club where they're saying, it is quite reassuring that these very small cannulas were used and it hasn't caused any ill effect. But I would be very cautious at applying that to the adult population, because a small cannula in a small person is very different to a small cannula in a big person. And if we can only get a super small cannula in an adult, there's usually other factors that have meant that is the issue, and the cannula is going to be really very short relative to the patient. So it's just being careful about application of this to other populations.
The other thing that came up in the discussion was only the ones in the hand that caused problems. So again, it's common sense, but if possible, put it into a bigger vein further up. And the other thing I thought was quite interesting, Christina, the pharmacist, said she can't remember the last time she was asked for phentolamine. So clearly, even though our practice is to start vasoconstrictors peripherally, it's very rare for it to extravasate. So I think that's reassuring.
And if you are going to start using it in your department, if you don't do it already, it's just simple things like checking the cannula before you start using it for that, really asking yourself, is it the best cannula we've got for this patient? And then regularly checking it to make sure that it hasn't. And one of the interesting things did they mention it in the study? Was it someone in the room said at the time, having a decent IV fluid flow go through the line at the same time, because you're far more likely to spot an extravasation if you've got 100 liters of saline sitting in the arm rather than the slow accumulation of noradrenaline sitting in the arm. So I thought that was a really good point.
It is a good point. If you're giving crystalloids, give them through the same cannula if they're compatible. Yeah. All right. Well, thank you to both our guests today. We'll see you all next time.